So, very good morning to everybody. I'm the fourth in the list in the controversies. So, I hope I don't incite more troubles. Rather, we can go at a consensus at the end. So, when I was given this topic by Dr. Vansi Sabu, this was the topic drugs you thought you knew all about, but what else do they do? So, for the first 5 minutes, I was just staring at the email. What am I supposed to speak on? How would I deliver to the audience? Then I suddenly stumbled upon the first Isha Stuti of Ishopanishad, which says that Purnamada Purnamidang, Purnat Purnamudachyate, Purnasya Purnamadaya, Purnameva Vashishyate. So knowledge is endless. Even if you take out a part from the full, you are still left with the full. So obviously the point would be discussed in the next 13 to 14 minutes would be what we have in our kitty from the scientific researches and what we usually do not discuss in our daily webinars, seminars in the evening. Because we talk so much about GLP and HGLD2, good things, bad things, etc. in ad boards, etc. So some other points will be touched upon today just to maybe stimulate each one of us whether these things actually translate into clinical benefits for the patients. So thanks to the entire team of Diabetes India, Bangshi Sabu sir, and also chairpersons for introducing me. And I have no conflict of interest, and this is very interesting that you can say both the good sides and bad sides of it, and you are free to talk upon science. So when you move along a national highway and you are very hungry, you see just neat and clean place to sit and eat, and then you ask for the washroom to wash your hands, and then you stumble upon the kitchen. You just knock the wrong door, and then you find this. Your entire hunger will disappear. So why I'm giving this analogy is that suppose a patient, Mr. X, who is 2 years diabetic on sulfonylurea and metformin, has an excellent HbA1c of 6.8. So are you happy with this lovable value of HbA1c? Maybe you should not be, because there's some other questions to be asked. What about the CV risk? What about the renal risk? What about the mortality risk? So as spoken by my previous speaker, madam, the diabetes management is not A1C or glucocentric. It has now become a package, though our patients do not actually tend to understand that. Doctor sir, mera sirf sugar kam kar dijiye. That's the only thing they talk about. So when you are looking at this beautiful place where there are rose petals strewn around, and then you look at other one, the difference is that the center is still the rose petals, but you have some good things in the periphery. Similar is the diabetes management of today. So center point will be sugar control, and you can have icing or cherry on the cake, which we will talk about in evening seminars and webinars. But we cannot forget that sugar reduction is still important. You can give fancy products which will give cardiac protection, renal protection, and then you have HbA1c of 9.5, you are truly doing injustice to the patient. So sugar reduction as well as other things become very important. The peculiarity of the pancreas and diabetes is that hypoglycemia is not compatible with life. And if you have hyperglycemia, the pancreas will weep and cry, but still the patient will live, maybe with some comorbidities, and then will reach the terminal phase. So obviously, this is the physiology that insulin is on one side, whereas all the other hormones, glucagon, growth hormone, cortisol, epinephrine, even thyroid hormones, which is not written here, is actually balancing this. What is meant is that everything is important. A good combination is important for survival. Just for a humorous exemplification, you can take this photo, but I truly say they should not have any political undercurrent. I just want to mean that is cooperative federalism. You need everybody actually on board for democracy to run. Now, how has the world changed around us in the last decade? So there have been a tectonic shift in the guidelines, as my previous speaker was saying. So pre-2017, you could have chosen any of the 6 classes of drugs without any bias or prejudice after metformin and lifestyle modification. But 2018 was a watershed moment when you have to scratch your head and ask, patient has ACVD, heart failure, CKD, hypoglycemia, cost issues, etc. And that is why it is the diabetes plus something that determines the choice of drugs. It is not only diabetes. Again, the same, alluding to the same point, that pre-2019, metformin was the unchallenged poster boy of type 2 diabetes treatment initiation. But the throne got jolted with the 2019 guidelines, where you can actually bypass metformin and give some other drugs which give some benefits. We know that karma is a bitch. So we do something wrong, maybe we're going to get it back. But the problem is, if you do not give the benefit of glycemic legacy to the patient in the initial years, it is the diabetologist karma which is going not to haunt the diabetologist, but the patient. So we have to be careful about good sugar control from the very beginning. Everybody's happy when you get a free gift. So you buy a toothpaste, you get a toothbrush free. So everybody's talking about the fringe benefits of molecules. But there are some dark sides as well when you are talking of various drugs. We should keep that in mind while we are using it. Now coming to the body of the presentation. We start with individual drugs like metformin. We all know that it does very good sugar control. Initially, it has to be used in most of the cases. But what else can we talk about? So remarkably, while in human studies, health promoting effects of metformin were mostly reported in diabetic conditions, in animal experiments, metformin exhibited beneficial effects, even anti-aging ones, in normal conditions as well. If you talk about geroscience, be it genomic instability, telomere attrition, nutrient sensing, etc., there are various studies. Hallmarks of aging and effects of metformin have some salutary benefits in all of the pathways. So these are all the studies. Coming to four other points on cancer, CVD, neurodegenerative diseases, and lifespan. I will just touch upon in one slide that metformin initially entered the spotlight as an anti-cancer agent due to its effects on various pathways like repressing the mTOR pathway, impeding tumor cell escape from immunosurveillance. In CVD, we know that metformin may reduce the risk of CVD by reducing body weight, blood pressure, cholesterol levels, and the progression of atherosclerosis. And we know that it inhibits the NF-kappa B pathway, so it has putative benefits. Cognitive function, there are a lot of controversies regarding that because it's very difficult to actually find out the separate effect of metformin from other effects. So cognitive decline could possibly arise from other concomitant conditions, and you do not prescribe only one medication for diabetes. So the practical impossibility to evaluate the exclusive effect of metformin alone in these cases is there. But still there are various mechanisms which state that it can have good effect in Alzheimer's disease. The Singapore longitudinal aging study in 2014 the authors had concluded that long-term metformin treatment in type 2 diabetes patients might reduce the risk of dementia and cognitive impairment. Coming to the last part with metformin is that aged population is actually increasing and we are actually preventing mortality but stretching the morbidity. So if you just project it like this is what we are trying to do. When non-communicable diseases like a century back was not so much prevalent, people used to die more of acute illnesses. Three-fourths of the life was in healthy phase, maybe the last part before terminal phase, the patient was diseased. But now a diabetic patient coming at 30 years of age, living till 70, that means 40 years is spent in diabetic phase and only 30 years, that is a minority, is spent in the healthy phase. So we are now talking about health span, not lifespan. So birth to death is lifespan, but health span means the healthy part should be stretched rather than dragging on the disease phase. So this is one important concept coming up and we should all focus on that. And for that, obviously, all the lifestyle diseases have to be addressed much earlier. I was talking the same in the obesity conference here only in Ahmedabad 2 months back. So mechanism action is not known. No evidence of such effects in humans have been seen, but maybe light will come at the end of the tunnel because geroscience is gradually progressing with a lot of research on these molecules. Coming to another molecule which is not very much discussed is pioglitazone. I have specifically picked up this topic because this needs relevance. So we will talk about the proactive trial which actually tried to see whether pioglitazone reduces cardiovascular morbidity and mortality in patients with type 2 diabetes. And what they showed that HbA1c median change from baseline was very salutary, but there were some problems with the study. Like the primary outcome was not met. So when your primary outcome is not being met, because you can see in the first line, the upper limit of confidence interval is 1.02. So it has touched the digit of unity. Then the secondary outcomes become exploratory or hypothesis generating. But still, it generated some interest and it was inferred that pioglitazone reduces the composite of all-cause mortality, non-fatal MI, and stroke in patients with type 2 diabetes who have high risk of macrovascular events. Then comes pioglitazone in stroke. Obviously, this is very important. Comes with the IRIS trial. But let me tell you, in all these studies, the dose was 30 to 45 milligram, which usually in today's world we do not use. We use only till 15. Maximally, I use in some patients where my cardiologists and nephrologists are not just firing at me at 30 mg per day. Otherwise, it is still at 15. But these studies showed benefit at a higher dose. So if PIO is effective in preventing future strokes or heart attacks, and this was the graph, obviously you can see the separation of the graphs, and the hazard ratio is quite interesting. The upper limit of confidence interval is very well within 1. So this definitely shows benefit. And also, median change in fasting blood glucose over time. That means those patients were actually not diabetic, and those who were in the pioglitazone arm actually had good sugar values, while the others show little bit of progression. This was a meta-analysis on secondary stroke prevention. They also inferred that recurrent stroke and major vascular events were reduced. So summary of the CVOTs for pioglitazone were actually good. But I will say at the end how we are actually deterring to still write pioglitazone, though it's such a good molecule in Indian setup. And there are some other benefits like effect in Parkinson's disease, decreased visceral fat. We all know that pioglitazone can cause weight gain, but actually it removes the stubborn visceral fat and maybe makes more subcutaneous fat. So that part has to be kept in mind, though patients overall gain a little bit of weight. In NASH, obviously this is important, which is now MASLD. So we know that fibrosis reversal is very difficult. We are still searching for molecules which can actually do that. But regarding the steatosis improvement, transaminitis improvement, lobular inflammation improvement, hepatocellular ballooning improvement, pioglitazone has a role. And that's why it has made its place in the various international guidelines. Coming to SGLT2 inhibitors, obviously I will skip because we all talked about heart failure. Suffice to say that earlier it was thought it will act in reduced ejection fraction. Remember that EMPA is available at 10 and 25 for endocrinologists, diabetologists, but if you are talking of cardiac renal benefits, the studies are with 10 mg. Early flows in HF, this I have quoted from the ESC one. Just look at the last line. Out of the 4 pillars of heart failure, you are more working with conviction if you are giving SGLT2 inhibitors. Initiate, continue, continue, and continue. Whereas others, you have to be a little bit cautious. So this is one of the main pillars now in heart failure management. So the gist is now the correction has come in the guidelines that use irrespective of ejection fraction. Even in preserved ejection fraction, post the preserve study and the deliver study, you can use the molecule. This was presented in Madrid ESD last year. Effect of SGLT2 inhibitor on graft survival in heart transplantation. They looked about 1,000 odd patients. They made 2 pairs, and they said that treating with SGLT2 had a significant reduction in the risk of graft failure, need for dialysis, all-cause hospitalization. Then there are reports on erectile dysfunction as well, that they potentiate the effect of tadalafil. So they did in Caucasian studies. There are studies with iron metabolism as well, anemia in CKD, and I noted this from a post hoc analysis of DAPA-HF as well, that it provides a unique opportunity to examine whether this class of molecules corrects anemia in patients with heart failure as well. Then MASLD, of course, there are studies with empagliflozin. I would specifically talk about the ELIFT trial where they had done in a small number of patients, but MRI proton density scanning was done and they showed that the visceral fat is actually coming down. So if EMPA is there, will DAPA be far behind? Obviously not. This is a list of meta-analysis where they showed generally that it also has the same benefit. So maybe it's a class effect. So it reduces the liver enzymes, it reduces the bad markers of lipid metabolism. And there are various mechanisms, but remember again the dose has to be 10. If somebody uses 5 for anti-hyperglycemic action, you cannot expect that it will act for NASLD as well. And there are some issues with polycystic ovarian syndrome as well, and they concluded that not only anthropometric and metabolic outcomes, but hormonal defects, that is the increased LH drive that happens in PCOS, can also be corrected with dapagliflozin. I'll just skip through these slides because of shortage of time. Urate transport reports are also there. Incidence of gout is also seen to be reduced. But when I say all these things, it seems everything is so rosy around. But problem is we have to understand whether these studies are adequately powered to understand these benefits, whether these outcomes were pre-specified at outset, what was the sample size, and whether there are any confounders in the study. Lastly, in kidney transplant patients also, there's an excellent article which I found out. They have even given recommendations where you can use this molecule, SGLT2 inhibitors in kidney transplantation. I'll skip this. And lastly, coming to GLP-1 receptor agonists, we talk a lot about this because it is progressing in leaps and bounds. We know that it causes weight loss, reduction in blood pressure is there, cardiovascular health and kidney health is well established, and also role in MASLD is coming up. So I quote this is hot from the oven, published in January or February only. It's a very good article mapping the effectiveness and risks of GLP-1. These are the expanded horizons. They are now seen that there was one problem with this suicidal tendency in EMA had asked for an investigation, but ultimately it was cleared for semaglutide. But not all is hunky-dory. We are still in the Valentine's week. But once you have finished seeing the good nail polish and the beautiful hands of the lady picking the flower, just look at the thorns there. So we have to be cautious about side effects. Your beloved should only get the rose, not the prick of the thorn and bleed, otherwise she will leave you. So when I write pioglitazone, this actually happens. I get resist. I'll just take 30 seconds. Resistance from 5 departments. Ophthalmologist telling me, no, macular edema ho jayega. My orthopedician says, no, BMD is so less, fracture ho jayega. My cardiologist says, no, ye water retention ho jayega, heart failure ho jayega. Nephrologist is also on the line. Even I get resistance from my own endocrinologist and diabetologist friends. No, weight gain ho jayega. But it's actually a good molecule available in India's market, and if it is judiciously used, it can do wonders. GLP-1, same thing. We should be careful about all these side effects. So in the last part of the presentation, whatever we have said about the controversies, the initial cues must be picked up. Remember, nobody knew SGLT2 inhibitor would cause good effects in heart failure. Only 4% of patients in the declared TIMI were actually having heart failure. And there was a subgroup analysis which found out, Are, isme to acha ho raha hai. Then a study was designed to find and look at heart failure. So this is how things evolve. So ultimately, today's pledge should be we should go for early control, sustain control, protect organs, and minimize side effects. Thank you.